Well, great. How about maybe we can tackle a little bit on transplant ineligible patients. What do you think about transplant ineligible patients?
There's so much. There's so many treatment options. But again, 3-drug is always better than 2-drug. That has been shown in several trials. But there's some patients who may not initially tolerate the 3-drug. So you start them on 2. So RVD again, or RVD light with the weekly Velcade that has been shown. And you had mentioned that, earlier with the RVD light, giving weekly Velcade for 3 weeks and 1 week off, and still the dose of Revlimid. The Meyer study with Dara-RD is a blockbuster for me. In fact, I'm kind of switching between RVD and Dara-RD. It's, those are such good, good outcome. And, that study, compared, Dara-RD was also a large study, over 360 patients. And the median follow-up was 28 months, and, showed that at 30 months, 70.6% of patients in the Dara arm were disease-free versus 55.6%. And then the CR also was really high in the Dara arm, 47.6% versus 24%. And then the Dara VMP was also just, published as the European study where they did, VMP as the backbone versus Dara VMP. That also had about 350 patients in each, and with a median follow-up of 40 months, showed that Dara VMP, the median progression-free survival was 36.4 months, so almost twice as compared to the VMP, which was 19.3 months. So all of those are really good options. I'm not sure, which, RVD and Dara-RD are really my first to go based on the trials. But again, in patients who have renal insufficiency, where the lenalidomide initially may not be an option, and also, the lenalidomide cannot be given inpatient, right? Unless you write the script, it takes a week. So patients who really need treatment, so the CyBorD, Cytoxan, bortezomib, dexamethasone, is a really good agent for patients with acute renal failure, and you're trying to, give them treatment right away. Cytoxan, bortezomib is really, really a great agent. And then, of course, KRD is another option, and carfilzomib, Cytoxan, Dex. So those are other really good options. I'm not sure, what's your favorite?
Yeah, I completely agree. I use CyBorD or VCD for the people who have renal insufficiency, but mostly everybody else gets RVD. It's a triplet, like you said.
Yeah.
I'm starting to use a little bit more Dara RD as induction. I think it's really extremely well tolerated. So we'll see how that evolves. And the last thing I'll say about transplant ineligible is maintenance therapy. I think we've shown in multiple settings, in multiple studies, including the first study, and Dr. Palumbo did a randomized study of no maintenance versus maintenance 10 years ago or more, using lenalidomide as maintenance, and continuous therapy always wins out. So in fact, usually I give people somewhere between 8 and 12 cycles of induction therapy, and then I do switch them to maintenance. And the same thing with the transplant ineligible, same thing, guidelines in my mind, most people get lenalidomide unless they're not tolerating it. And then I go to bortezomib every other week and give them bortezomib every other week and watch them for neuropathy. So that goes good.
So that's another area of contention. How long is maintenance, right? So the Europeans do 1 year, maybe because of their, medical, insurance that they have. But here, actually, I did a debate in the NCCN last year in September. So they gave me the role of, fixed duration of maintenance versus continuation. Even though I do continuation of maintenance, but of course, that's a debate area. How long should maintenance be? And it's really all over the place, right? But, the BMT CTN 1702, this was the 3-arm study that actually looked at single auto followed by maintenance as the standard versus auto followed by maintenance, or auto with consolidation, VRD followed by maintenance. The initial was actually 3 years. In fact, I'm proud to say that my patient was the first patient on that on the study, you know, and he's doing well even 10 years out now, still on maintenance, you know, lenalidomide. But after 3 years, we decided to do the long-term follow-up and give patient the option to either continue maintenance versus, you know, stopping. So some patient decided to stop. I think it was about, so the at the ASCO this year, they presented, you know, the long-term follow-up of the BMT-CTN1, you know, 1702. And what it showed that patients who continued beyond 3 years, you know, actually had, you know, an improved PFS compared to those who stopped. You know, they were in remission or stable, or, you know, disease was stable, VGPR or PR, but when they stopped, you know, the disease progressed earlier than those who continued maintenance. So that's really the first study that has shown now that beyond 3 years, there is a benefit for len maintenance beyond, you know, 3 years. So, and patients too, you know, they read and they see this, and I've had patients who, you know, say, I want to continue. I'm doing very well on it. I don't want to stop, you know. Of course, you talk to them about the risk of second primary malignancies, you know, which is about 78% compared to 4% in the placebo group. But with the 67% benefit, increased benefit, patients say, look, I'm going to continue and take my my chances. Yeah.